morning. Graham Kiefer, training videos around Australia, back at Truscott Air Base at the moment. So this morning we're going to talk about arterial blood gases. Right? As paramedics, we come in contact with certain patients that may require blood gases to be taken. That could be either arterial or venous. And we've got to then determine our treatment regime, or we pass on the information to our telehealth doctor or receiving hospital. And from there, they can work out a treatment regime in regard to their ventilation, drug therapy, or fluid administration. So why do we do that? Well, we have to have, from the patient's clinical stage, we have to have an evidence base of how they are. We collect observations, blood pressure, oxygen saturation, pulse, heart rate, ECG. So blood gases add to that type of point of care assessment. So that's why we do it. So they're performed by a trained physician. Either the radial, the brachial, or the femoral area is accessed to draw off the blood. There are complications. You can get like hematoma, arterial spasm, arterial occlusion, and more bleeding that may have to be put over the side for about 5-10 minutes to stop the arterial bleed. So from the information that we've gathered, we can then work out what treatment we're going to implement. So maybe increase oxygen therapy, increase ventilation rate, increase drug administration, fluid administration. And then we can monitor those trends by taking blood gases regularly. So, like I said, there is complications from this. So when we get the results from the machine, we've taken our blood, put it in our EPOC or our iStat machine. It's printed out a small strip of paper that we analyse. So what we have to look at, obviously the patient first and how they present, and then we get some props. So what I've prepared is a few little props, excuse me, and at the moment we've got to look at the pH. So I'm between 7.35 and 7.5 at the moment. That's my normal pH. I'm operating that right now. So if I was to go that way to the right, then I'd be more acidotic. Or if I was going that way to the left, increase in pH, more alkalotic. So that's important. Then we determine either patient is alkalotic or acidotic. Well, very easy to do. Straight away we look at our results. Now, then we look at our PCO2. At the moment, 45 millimetres of Hg, 35 millimetres of Hg. Excuse me for the cough. So that's a normal range that we look at for arterial blood gases. So obviously, if that drops down, then we're looking at a low PCO2 if they're alkaline, which could be respiratory alkalosis. So if the PCO2 on this area, we already know if this patient's acidotic and the PCO2 goes up, then that's respiratory acidosis. So that kind of gives us a good idea of what's going on. Now from that, we look at another thing with collection of hydrogen ions. Hydrogen ions collected and buffered in our system, right? So at the moment, again, hopefully I'm operating between the levels of 26 plus or minus millimoles or 22 plus or minus 2 millimoles. All right. So we look at these. So we've looked at the pH, we've looked at the PCO2, and we've evaluated either their acidotic, or alkalotic, respiratory alkalotic, or respiratory alkalotic. But then we look at these HCO3. So if we have like a low HCO3 and the patient is already acidotic, then we know that the patient is metabolic acidosis. Easy to do. We also have a cheat sheet which we can read off too. So if we have a high HCO3, then we know, and the patient has already been determined by their pH as alkalotic, then we have metabolic alkalosis. These is kind of like the steps that we look at. pH, PCO2, HCO3, determine that. One other factor that we do look at in our blood level is our lactate levels. Now lactates is a function of then the mitochondria between aerobic and anaerobic metabolism. So when we can function, if the lactate is above 1.92, then we know down at the cellular level that it's aerobic anaerobic metabolism is going on and heaps of lactic acid is being produced. So there's another function that they call lactic acidosis. You know, we've looked at the patient. You know, their pH is low, so they're acidotic. And we've worked out that their PCO2 is high, so they're respiratory acidotic. So these things come into play. And then if we can adjust our ventilation rate, oxygen therapy, infusion rates for fluids, and drug therapy. So blood gases is an interesting subject to look at, but we've got to take into account that we may not be able to get arterial blood gases because we're not trained that. We can only get venous blood gases. Now, in the venous blood gases, the pH only changes 0.3, so it's 7.33 to 7.44. So the HCO3 is within a +2 or minus type of range. What changes the PCO2? Because it's already a collection from 41 millimeters of mercury to 57 millimeters of mercury. That's our range there on our venous blood gases. So it is important that we look at this, and it's also important that you have a cheat sheet that you carry around to be able to help you to analyse these blood gases. And there's nothing wrong with carrying around information to be able to have a reference base. So study your blood gases, do that simple procedure, work out their pH, work out their PCO2, and then work out their HCO3 and their lactate level. And from that clinical status of the patient, then determine treatment or pass on that information to the doctor on telehealth or the receiving hospital. Thank you again. All the best.